I think one of the things that's coming across, and I'd like to emphasise, is how we see harms from medicines comes from our perspective, whether it's from a societal perspective, from a clinician's perspective, but also from the patient's perspective. And I imagine in the room we've got people from different professional backgrounds, but also from policy, and also, really importantly, I think we need to take into account the patient's perspective around harms from medicines. And adverse effects and negative effects associated with medicines has been around for a very long time, and people have written about these side effects from medicines from the earliest of writings. In fact, the very first newspaper ever published in the United Kingdom carried an advertisement for medicines about how the newest non-mercurial medicines in the treatment of sexually transmitted diseases was going to be safer. So right from the earliest of times, there's been a focus on trying to have safer medicines. But I think perhaps more recently we've had a stronger focus at a societal level because of the recognition of the increase in health service utilisation associated with some of those harms from medicines. Because it's estimated that about 1 in 4 adverse events in older people is considered preventable. 1 in 3 unplanned admissions to hospital in Australia in people aged over 75 is related to their medicines. So that translates to about 230,000 hospital admissions, 500,000 presentations in general practice at a cost of about $1.2 billion. And that means there's more medicine-related admissions to hospital than for asthma, diabetes and heart failure. But as Craig said, it's really important to think about what those adverse events are that are resulting in that health service utilisation. Because we do have compelling evidence that medicines do relieve suffering, have made a difference to morbidity and mortality. And we're weighing up always as clinicians the benefits and harms. And for example, some medicines that we might use to reduce a stroke, or they might be medicines we're using to relieve symptoms such as pain relief. On the iatrogenic burden side of the equation, for example, with our stroke risk reduction medicines, we may cause bleeding or hemorrhage risk. But also with our medicines that we use to relieve pain and suffering, particularly the opioids, they can contribute to dry mouth, constipation, and also, importantly for older people, it may affect their independence. It may contribute to confusion and sedation. I want to talk a bit more about that. Because as we try and balance up the benefits and harms of medicines, and certainly with stroke risk reduction medicines, it might be about monitoring INR testing, for example, to try and keep them in the therapeutic range. For the relief of pain, it might be, for example, recognising that some of the medicines that we use to relieve pain might put them at increased risk of falls, and then it's about adjusting the dose and perhaps proactively implementing a falls risk reduction strategy, not waiting for the fall to occur so that we get the balance right, and maybe even tipping it in favour of the benefit by addressing such things as dry mouth, constipation, and also factors that might be associated with the medicines like urinary incontinence. Because as was said, I thought it would be important to focus on some of the other harms and side effects associated with medicines that are often the ones that patients worry about. Clinicians often don't talk about constipation and urinary incontinence, and yet for older people, it can sometimes be the final straw for their independence. Because in therapeutics, and this was a photo taken at a pharmacoepidemiology meeting that I attended, and it seemed a very good symbolic way of therapeutics, and this was taken in Copenhagen, because therapeutics does stand on these two pillars of efficacy and safety of the medicines. As I've tried to point out, medicines have achieved benefits, but there's also the harms associated with medicines. The trouble with the clinical trials is that most of the medicines, the emphasis on the efficacy, and not much consideration is given to the harms, and particularly in older people, and also harms when they're in people who have multiple comorbidities. So it's not just one harm associated with one drug, there might be multiple harms and that interaction. So our goal is around maximising outcomes and minimising harms. And one of the other challenges for clinicians is that the full safety profile of the drug might not be known when it becomes available. And Craig has highlighted a lot of those examples. And fortunately, we have prepared our slides in a way that we won't be duplicating them but certainly a lot of those types of side effects, the anticholinergic burden, the drug burden index, the association of that additive anticholinergic burden risk has only been really recognised in more recent times. Some of the drugs that we might use for treatment of diabetes and other clinical problems, the adverse effect profile emerges over time. But importantly, we do need to take into account patient preferences, and sometimes as clinicians we might preference managing their pain over independence, over being awake and alert. We need to think about those patient preferences. And so this is just an example of through whose lens. Now, this is a very famous painting of Van Gogh, and some of you will recognise these pictures. Now, some people would present them as the light of Arles, and in terms of the perspective, if you were the psychiatrist caring for Van Gogh at this time, it may have been represented as, for example, his delirium that he was seeing some of these, and he was painting that. But as a pharmacologist, looking at this particular painting of Van Gogh, that's his physician, and his physician is holding the foxglove, otherwise known as digitalis, which Craig has already highlighted increases your risk of nausea and potential falls risk. But as a pharmacologist looking at this particular picture, one of the toxicities of digoxin is actually you see orange halos around the light. So this could well have been drug toxicity leading to these famous paintings. However, older people and harms from medicines from a pharmacy perspective, many of the speakers this morning have highlighted the increasing number of medicines, but also the increasing duration of medicine. We're often starting medicines earlier in life, and then people may be on the medicines for 20 or 30 years, and their therapeutic goals and their ability to, if you like, tolerate some of those side effects will change across that time period, increasing potential for drug-drug interactions and drug-disease interactions. But I want to come back to the point where I gave those figures around admissions to hospital related to drug-related harm and emphasise Craig's point again. As you can see here, the biggest circle is actually medication-related problems, not specific adverse drug reactions or adverse drug events. And those medication-related problems, when you look at that literature, a lot of those admissions to hospitals relate from people not taking their medicines. So it's actually underuse of medicines in some cases where they're not taking their medicines for heart failure and therefore present. So I want to put it in a more balanced way that some of those medication-related problems do come from when people aren't taking their medicines. And so this graphic also is I'll just walk you through that very briefly, but this is taken from some clinical drug trials where they have been able to really carefully look at adherence. And in this first picture here, the grey columns, they represent where a patient has been given a prescription for a medicine but they haven't started taking it. So maybe a week or 10 days goes by before they start taking the medicine. It may well be an urban myth around Adelaide, but there is a story that goes something like this, that at one of the general practices where they had a hedge out the front of that GP practice, that over time they decided to cut down that hedge. And in doing so, they found a lot of crunched up, screwed up prescriptions poked into the hedge. So that as patients left that practice, they didn't ever get the prescription dispensed and therefore didn't take it. But in this case, so it highlights that this is one form of poor adherence, is that people might not be taking it for a number of days or weeks and then they start taking it. But this has implications for us all as clinicians, because if we think they started taking it then, and then they represent about this point, we may well add another medication to relieve the problem because they haven't responded, but it might be poor adherence and we need to be alert to that. So this is non-adherence where people are not starting. This is reflecting a twice daily dosage where the blue dots represent that they took the medicines in the morning and the blue dots are when they take it in the afternoon. So let's look at this second scenario. Here we've got a patient who is going along quite well and has taken their medicines regularly morning and night. And they seem to be doing very well. But then, this point here, they just stop taking them. And there are a lot of people, they're the sort of people that lead to Craig's slide where they accumulate in the cupboards of their home. But as a clinician, we need to be alert. So they could have been very good at taking their medicines. And there might be other reasons why they stopped taking them. And I suppose for some of the medicines like opioids, we need to be alert to that because that may put them at risk if there's unused medicines around. And then this type of scenario here where they're not very good at taking them in the mornings for a variety of reasons, they take them in the afternoon, and then they have periods when they're not very good at complying. Because otherwise we wrap everything up into a statement that says someone's got poor adherence. But as you can see in just these three examples, that poor adherence can take many forms. And the way in which we interpret that poor adherence and as clinicians respond to that could lead to over-prescribing, under-prescribing, or potential risk for harm if those medicines are, for example, opioids. Because there might be very good reasons why this person suddenly stopped taking them. It might be because they've been getting side effects or for other reasons, so we need to be alert to that. Craig's talked about some of the different types of tools that are used now to try and, if you like, quantify harm from medicines, and this was just one of those. The psychotropic drugs are well known for harm in older people and the way in which that harm manifests, both increasing morbidity and mortality. So the antipsychotic medications have not only increased morbidity, but they are associated with increased mortality in older people. But how we see adverse effects as clinicians is not a series of drugs. And as a pharmacist, it's not about defining a person by the medicines they're on or that they're just a drug list. But importantly, as clinicians, some of the ways in which harms from medicines manifest or present are these sorts of things. So someone might present with increasing dizziness or falls or agitation. And I just wanted to, and you can see there's a number of others there, but I just wanted to focus on agitation. And one of the common forms of agitation, and particularly in those people who are prescribed opioids, for older people, they might also have concomitant nausea. And so often a common co-prescription is metoclopramide in people who are on opioids. And yet metoclopramide is very commonly associated with akathisia. And if anyone's ever suffered from akathisia, it's that sort of restlessness and agitation. And in fact, we have seen in a number of people prescribed opioids, it may not be the opioids that contribute to the falls, but the Maxilon that's co-prescribed, which leads to agitation and sometimes gets overlooked. My little Van Gogh to show you that through whose lens are you looking. Certainly people often overlook the Maxilon, which might be actually the agent contributing to that falls risk, and agitation. And that agitation may well then lead to a prescribing cascade where they might get something to relieve that agitation and suffering, and so a benzodiazepine. And I'm sure that you can all think of your own examples where one adverse event from a drug leads to the co-prescribing of another drug therapy. And and thinking about those perhaps over lunch. But here are some of the other examples. And the top one I wanted to highlight in particular, because cholinesterase inhibitors, Craig's given a whole lot of discussion around anticholinergics and cholinergics, but cholinesterases are the drugs that are used to, in people with dementia, to try and eke out the last little bit of acetylcholine. But it can lead to incontinence. And it can lead to being doubly incontinent, both urinary incontinence and fecally incontinent. And one of the prescribing cascades is that people then might well be given drugs to, like a drug called loperamide, to stop the fecal incontinence. And occasionally we see someone stops the acetylcholinesterase, but again, a bit like the metoclopramide, forgets about the loperamide, and then we've seen in the recent times people then presenting with bowel obstruction and bowel perforation. So we have to remain vigilant to the prescribing cascades. And as lunchtime approaches, and perhaps people have been sitting here for a little while, you don't need a randomised controlled trial, although there has been some more recent evidence to suggest that those people who have a full and distended bladder can be associated with agitation. So, and so thinking about urinary retention leading to that sort of agitation, again in older people, where we give drugs that have an anticholinergic effect or cause constipation, can lead to some of these other side effects. One of the geriatricians in Boston at Harvard, Jerry Avon, he talks about any new symptom in an older person should be considered a drug side effect until proven otherwise. It's one of the few things we can do something about. It doesn't mean that all all of the symptoms are related to side effects, because we do get them wrong. And sometimes the certainty, just because they're written down, implies that there's more certainty. And this is just an example taken on that same European trip. Barriers to stopping medicines, however, sometimes are that we don't have enough evidence, and again Craig talked about there might be system barriers, and it's a bit like your comment about it can be noted but nothing done about it. People know that they're on some of the benzodiazepines, the psychotropic drugs, but also there are patient barriers sometimes to stopping. People have been taking them for a long time and may be concerned if those medicines are stopped. So again, just a couple of points in closing is that thinking about using a medication list can be important, and there are a number of those available. The National Prescribing Service, or NPS Medicine-wise, has that. They also had a program on older and wiser, so that seems to be the thing of the moment. And we've talked a bit about the physiological changes in the elderly, but again, the renal function, I'm not going to go into that. But I did want to just highlight, given some of the discussion around smoking cessation, that if there are a number of medicines that are affected by clearance through the liver, and sometimes when we actually manage to get someone to give up their cigarettes and stop smoking, we can actually increase the plasma concentrations of some of their medicines and lead to side effects. So we again need to be alert to the changes in the pharmacokinetics of medicines if we manage to get people to stop smoking. It's not all medicines, and we have an expert in the room on that at the moment, but it is something that sometimes gets overlooked and can lead to problems. And this was just one of the things I did want to highlight, which is the point that Craig also made, which is that for older people, their ability to tolerate some of those harms from medicines may become more narrowed because they don't have that reserve. And they might well be tolerating some of their medicines when they're well, but when something else happens, such as a fall, maybe heart failure, maybe an exacerbation of their airways disease, pneumonia, their ability to tolerate some of those side effects may be changed. And so the symptom cascades. And the last thing before lunch I just wanted to talk about was dry mouth. Many of the opioids that we use, and I'm not going to go into the statistics on that, but many of the opioids we use, we know they cause constipation, but they also cause dry mouth. And so in older people, and sometimes in those people that have a history of drug misuse, they may have what we would call complex mouths. They may have had not the ability to have good dental care over their life, or they may have increased dental caries that have led to loss of their teeth, which may mean they have partial dentures. And as a consequence of having partial dentures, when you then cause a dry mouth, then they may well take out those dentures. They've got sore mouths, they may not be able to eat in the same way. And this leads to one of the cascades that Craig emphasised, is that they may start to not eat as well. They might not eat the protein and the meat, and therefore lead to some of that weight loss, simply as a side effect that often gets overlooked. And dry mouth can be a particular problem in older people, and many of the drugs that we prescribe, many of the opioids, can lead to dry mouth, and that list will be available for you. Also, dry mouth has sometimes been associated with one of the responses is to drink more water to relieve that, which can then lead to that cascade of incontinence. And just to highlight that urinary incontinence in men is about third that in women until the age of 80, when the rates converge. And one survey of older, frail, community-dwelling people found that they were about the same, and that it does increase the risk for falls. So maybe that will be the point at which I might leave my presentation, just to highlight that urinary retention can lead to agitation, that rushing to get to the toilet can lead to a falls risk. So with that note, I'll close.